Chairman Guthrie and Ranking Member Eshoo for holding this hearing today and for our panel for your testimony. Healthcare costs are something that every American faces, and even planned costs can represent substantial hardships for the hardworking constituents that we represent. Costs continue to keep rising, and we must be looking closely at this issue and working together to find solutions, such as getting the Lower Costs, More Transparency bill signed into law. In 2024, total federal spending on Medicare, Medicaid, and inflated ACA subsidies will eclipse the size of the discretionary budget. This is not sustainable, nor is it resulting in better outcomes. In fact, life expectancy in the U.S. has fallen back to levels that we have not seen since the early 1990s. Overinvestment in some areas and underinvestment in others has led to issues such as reduced access. It has caused misaligned incentives across the entire healthcare delivery system, resulting in increased costs. It has lowered efficiency, and it has only accelerated declining outcomes. One such area of underinvestment is in the way Medicare compensates physicians. Even before rampant inflation and the COVID-19 pandemic, physicians were facing an unsustainable trend. When adjusted for inflation, Medicare physician payment already has effectively declined 26% from 2001 to 2023. And that is before additional inflation, and these cuts are factored in. Also, physicians saw a 2% payment reduction for 2023, and then again since January 1st of this year, a 3.7% cut. Ever-thinning margins increased pressure for independent physicians to consolidate with hospitals. Dr. Ippolito, could a policy that advances site-neutral payments and reinvests savings into physician fee schedules lead to less hospital physician consolidation in healthcare?
Yes, and it would also attenuate the reductions in revenues to the hospitals themselves because, of course, that would increase the new payment rate, which is the fee schedule. So yes.
Dr. White, seeing how this continued underpayment has driven consolidation and required seniors to receive care in higher cost settings like hospitals, outpatient departments, how does the CPO account for these increased government outlays from consolidation when weighing the direct budgetary cost of providing necessary relief in the physician fee schedule?
Thank you for the question. So if policy were to shift from the current flat physician fees to being pegged to the Medicare Economic Index with automatic inflation adjustments, that would imply substantial federal cost increases for physician fees. If it were coupled with a substantial site-neutral policy, we would take into account whether that would dampen consolidation and maybe change the site of service, but we'd have to look at that carefully.
And I think these are issues that we need to continue to look at very carefully as we drive physicians away from accepting Medicare patients. On another topic, driving increased mortality rates, heart disease is one of the top causes of mortality and expensive hospitalizations among our Medicare beneficiaries. During the pandemic, flexibility for seniors to perform cardiac and pulmonary rehabilitation at home through telehealth waivers led to greater compliance with their care regimens and, in turn, fewer re-hospitalizations. Dr. Ippolito, there is data to show that cardiac rehabilitation can reduce hospitalizations by 30% among eligible beneficiaries. How can we best incentivize this high-value service and others like it that reduce patients accessing our healthcare system through the emergency room and other high-cost settings?
Well, the simple answer would be to make it financially worthwhile for people to provide, so through reimbursement probably.
And continuing access to those outpatient rehabilitations through telehealth is an important cost-cutting measure.
I'd have to think more about the specific policy, but it certainly could be.